Regenerative medicine is relatively a new field where we use our body's own products, platelets, stem cells, to help our body heal. It's even newer in orthopedics. Stem cells have been used in hematology and oncology for years. You may have had people that you know that have had blood disorders where they've gotten bone marrow transplants. Bone marrow transplants are basically taking your body's stem cells, getting them to divide, and being used in other parts of the body. As advanced as we think we are in the United States when it comes to medicine, when it comes to regenerative medicine, we're actually pretty far behind the rest of the world. Okay? The rest of the world, South America, Korea, Japan, Asia, Europe, they've been using stem cells for a lot of years, and they're a lot more advanced in terms of what they can do with it in most specialties. But it's recently taken root here in the States. So when you hear about biologics, that's what you're talking about, platelets, stem cells, those sort of things. And basically, there's a gap between people who don't need surgery and people who do need surgery for various problems. And tonight we're going to focus on some orthopedic problems, mainly osteoarthritis and breakdown of the tendons being the tissue that attach muscles to bones. Okay? And it used to be that if you had osteoarthritis or you had problems with your tendons, really your only treatment options were non-steroidal anti-inflammatory or corticosteroid injections. Recently, over the last 7-8 years, joint fluid therapy, which is a medicine we can put in various joints to stimulate the cells that line the joints to produce a new lubricating joint fluid. It's a pretty effective treatment. There's really no downside to it. It's not a cure, but it's helped people for years that have osteoarthritis. Now, in this country, joint fluid therapy and viscosupplementation, most insurance companies only approve it for the knee. But we've treated a lot of patients where we put it in their shoulder and we put it in their hip, and we've had very good results. What we've done with those situations, we actually have our patients get the medicine from Canada because it's a lot cheaper, and they bring it here to the office and we put it in the joint form. So there's ways that you can work around that. But the World Health Organization, musculoskeletal injuries by far the most common cause of long-term pain and physical disability. Diabetes, heart disease are also big problems. But I don't have to tell anybody in this room, as time goes by, our bodies start to wear down and we start to hurt more. So this is something that you don't already know. Okay, so first we're going to talk about osteoarthritis. Okay, there's different types of osteoarthritis, but mainly we're going to talk about the ones that affect the major joints of the body. There's also different types of arthritis. There's a type of arthritis that's caused by our immune system attacking our own tissues. That's things like rheumatoid arthritis, lupus. Those are treated completely different ways because you're trying to get your body's immune system to understand that the tissue it's attacking is its own. Osteoarthritis is usually due to one of a couple factors. One is an injury to a previous joint. Maybe when you're in high school you hurt yourself playing basketball or playing football, or maybe you were in a car wreck and you tore up a hip. Genetic factors play a huge role in osteoarthritis. Getting osteoarthritis is no different. The predisposition to getting osteoarthritis is no different than having blue eyes versus brown eyes, losing your hair, getting diabetes, heart disease. And oftentimes it can be a combination of both. You may be susceptible to getting osteoarthritis, and then you have an injury and it takes over at a very young age. Okay? But the one common denominator that happens with osteoarthritis is the loss of homeostasis in the joint. Okay? And what homeostasis is, there's a constant turnover of substances in the joint that keep the joint healthy. In other words, if you have bad osteoarthritis in your knee, why don't you have it in your fourth knuckle? Okay, everything's still working in your fourth knuckle. Something happened in your knee. Okay, and we'll talk a little bit more about that in a little bit. Basically, what osteoarthritis is and the way I explain it to my patients is this blue material that you see here on the end of the bone, okay, that is identical to what you see on the end of a bone when you break a chicken leg apart, that yellow gristly material. We have that on the end of our bones, and the wearing away of that material, like you see on this slide over here, that's what osteoarthritis is. Okay, it's the gradual wearing away of this blue material here, so instead of having a nice smooth surface where the bones glide across each other, you get a lot of rough spots. Okay, I tell my patient it's like driving down a road in Cleveland, it's full of chuck holes. I try to use good analogy, but I had a patient had moved up here, her husband worked for P&G, and I use that analogy for chuck holes, and she goes, "Doctor, I don't understand, what's a chuck hole?" I said, "Okay." I said, "You have to go up north." It's, you know, but and this will fall off. This cartilage mostly wears away, kind of like paint flaking off the ceiling. Okay, if anyone in this room has osteoarthritis, you know that constant dull ache that's there. Okay, I've had 3 knee operations, both shoulders twice, so you kind of have that achy soreness where if you overdo it, you know it's there. That's the way we lose our cartilage. It's kind of a dull ache that's there. And the other way it happens, like I say, it's kind of like your tire going over a chuck hole. If you have a rough spot, like you see here in this knee here, and you don't necessarily have to have a traumatic episode, that cartilage will sometimes spontaneously fall off, or if you twist your knee, you knock a piece of cartilage loose, and then it floats around inside the knee joint gets angry, or the hip joint, it kind of swells up, it gets stiff, you can't hurt it, you can't move it. And most of the time, after a few weeks, if you have loose cartilage floating around inside your joint, the body kind of dissolves it on its own, and your knee kind of goes back to baseline. Every once in a while, what happens is not only do you knock a piece of cartilage off, but you knock off the underlying bone with it. That usually doesn't go away. Okay, that's what we call a loose body. It can happen in any joint. When you have a loose body that doesn't go away after a few weeks, it needs to be removed arthroscopically. You know, stem cells and platelets, they're not going to remove loose bodies. Having a loose body in your joint is kind of like having a piece of dirt in your eye. Okay, you have a piece of dirt in your eye is constantly irritated, you're making tears, the water's going out. Same thing happens inside a joint. There's something irritating the joint makes fluid, but because there's no place to go, the joint continues to swell. And if that's the case and you have something loose floating around inside the joint, what it will do, it'll rub against these other areas there and just cause more cartilage to wear off, or it can get stuck between the bone and cause the knee to physically lock. Okay? And so the other thing that will happen with osteoarthritis is the cushion that sits between the bone starts to wear down. That cushion's called the meniscus. Okay? Now, you can injure a meniscus without having any osteoarthritis, but it's pretty unusual to have a normal-looking meniscus with a lot of osteoarthritis in the knee, because this wear and tear process that you see over here in the left picture, it will take down the meniscus with it. Okay? And again, why does the osteoarthritis progress? In other words, if you've had some cartilage loss in your knee, why doesn't it just stop? Why does it keep going? And it kind of goes back to this concept of called homeostasis. And basically what that is, it's maintaining a normal balance of chemical compositions in our body fluids and our different body parts. Okay? The way to look at it, it's like an ecosystem where you have the soil, you have plants in the soil, you have the water coming down, you got the sun, and you got the wind. All those sort of things need to be there in a perfect balance for that to work. Let's say you've got a nice garden growing, you've been working hard at it, next door a chemical plant moves in. Okay? Well, now the runoff from the chemical plant starts to go in your soil. And all of a sudden your tomato plants start to die. You're trying to figure out what's going on. You can have all the sun, you can have all the water, you can, but if your soil is bad, the plant's not going to grow. So what happens basically, excuse me, when you have an injury to a joint, or you have some genetic factor or some sort of toxin gets in your body, that homeostasis is disrupted. Now it's almost like you have a toxic environment inside the joint, and the body has lost its ability to repair that particular joint. And again, think if you have osteoarthritis in your hip, your knee, or your back hurts, but you haven't had any injury to the knuckles in your finger or to your left elbow, that all keeps working just fine while your body ages, but this one bad joint doesn't get better. It's lost its ability to kind of repair and remodel itself, okay? So I just put this slide up here to kind of illustrate that. This is just a picture of a knee joint, and we don't have blood inside our joints. We have a joint fluid, okay? It's kind of like the viscosity of the hand soap that we use, okay? And the cells that line the inner part of the knee here, it's kind of like a sleeve over it, they are producing on a daily basis molecules, protein, enzymes that constantly rebuild, regenerate, okay? But if you have an injury, what happens is now your body starts producing all these substances that break down cartilage, that break down bone, that cause pain and cause inflammation, okay? So if you can't put a stop to that, the arthritis progresses over a period of time. And that's the first thing that happens when we use platelets and stem cells in an arthritic joint, okay? It's going to shut down the production of these harmful products and then start production and get that homeostasis back, okay? So what does osteoarthritis look like, okay? These x-rays here, they're fairly normal x-rays, a couple little bone spurs there, but you see the nice space between the bones. The reason that you have the space between the bones is you have that blue cartilage I showed you on the end of the bone, and then you have the meniscus or the cushion between the bone, okay? So as osteoarthritis progresses, the joint space gets narrower, and then pretty soon the knee starts to look like this, where you have that bone-on-bone change, and the bone also changes in color because it gets at certain times harder, at certain times a little bit more brittle, but it's not turning over the way it should, so it changes its characteristics as well, okay? Now, looking at a knee joint here, which is probably the most common large joint that gets osteoarthritis, is you can get, you know, when you go see your doctor, they tell you, well, it's medial compartment or it's your kneecap. There's three sections or compartments in the knee. One is the inside. This is the inside of the knee. This is the outside of the knee. You can always tell because it has a small bone out here. That's your fibula. Over here, this looks pretty good, but here you have bone on bone. The inside part is called the medial compartment, okay? You have another part of the joint, okay? You have this groove here at the end of the thigh bone, and the kneecap moves back and forth in that groove, kind of like a rope in a pulley, okay? And what happens is as the cartilage wears down, kneecap moves back and forth, and then you got bone on bone in the patella or the kneecap problem, okay? And then you also have it on the outside part of the knee, okay? Where the inside part is okay, the patellofemoral part is okay, but the lateral compartment is shot, okay? And in terms of ability to treat, this is the most common, fortunately, and that's usually the one that responds the best. The patellofemoral compartment, depending on how much you got here, how much you there, responds well, but you know, if most of the osteoarthritis is in the lateral compartment of the knee, what we found is, you know, platelets and stem cells don't work very good for that. That's the sort of arthritis because of the mechanics of the joint and how you bear weight on it. It can be very difficult to treat unless you get a joint replacement, okay? And again, there may be other people that tell you otherwise, but I'm just telling you what we've learned here over a number of years, that there's things where this works great and there's entities where it doesn't work at all, okay? This is showing a hip here. Again, a little color change. On this hip here, the artists decided they're going to make the cartilage pink, okay? But it's the same sort of thing. You do have a cushion between the ball and the socket in the hip. That's called a labrum. It's a fibrocartilage. It does the same thing as a meniscus does in a knee. And again, what happens as osteoarthritis progresses, the cartilage wears down, the space between the bone gets narrowed, and the hip loses its ability to function in normal fashion. Okay? This is an x-ray of a hip here, and this is a fairly normal hip over on the left side. You see the nice round head of the femur and the thigh bone. You see the socket here, which is called the acetabulum, and you can see the space between the bone, and you see that space because there's cartilage on the end of the bone and the labrum is there. And when you look over here at this hip, it looks completely different. Okay, that's what osteoarthritis of a hip looks like. You can hardly see the joint space because it's kind of obliterated. And what happens when you start losing cartilage and the body tries to repair itself, it lays down bone kind of in a haphazard fashion. Does it wherever it wants to, not the way it was made when we were in the uterus and everything came out perfect. Okay? So that's one of the reasons that you get these bone spurs and rough spots, because the body's just putting bone, it doesn't know how to repair it, so it just throws it down and walks away. It's like having a bad contractor. Okay? This is a shoulder here. Okay, normally the shoulder bone's called the humerus. It usually has a nice round spherical head, and it sits on this bony part of your shoulder blade here called the glenoid. And again, there's a nice space in there. And one of the things that's vastly different between the shoulder joint and the hip joint is if you look at this x-ray here, you see how that's a very deep socket there. Most of the ball is sitting in the socket. The hip is a solid joint. That's why most people, unless you're in a car accident, tend not to have, I mean, you can get one playing football, but it usually takes very high energy injuries to dislocate a hip. When you go over here at the shoulder, okay, you can see that it's not a very deep socket at all. It's kind of like a golf ball sitting on a tee. It doesn't take much for the shoulder joint to go out of place, and if the rotator cuff, which is the group of muscles that holds the shoulder in place, gets damaged, now instead of the shoulder just kind of rotating on one place back and forth, it just kind of moves up and down and toggles, and then you get these bone-on-bone changes where you can't move the joint and you can go up and you can barely move your shoulder. Okay, so it affects most of the major joints. I don't have, osteoarthritis. If you've had an injury, can affect any joint. Overall, knee osteoarthritis is very common. Actually, the most common joint in females is this joint here at the base of the thumb called the basilar joint. That one tends to wear out first, and we've also had some success in treating that joint as well. But it's also very, very common. So the other thing that happens with osteoarthritis is not only does the cartilage on the end of the bone wear away, okay, but the connective tissue that holds the bones together gets to be like a rubber band. It doesn't go back in place. So a knee is made to move back and forth like a hinge. But if the restraints or the ligaments on either side of it get stretched out, now your knee starts to do that and it wobbles back and forth. So that kind of adds insult to injury. Not only do you have pain from the osteoarthritis, but now you have a joint where it feels like it's going to give out on you because that connective tissue is stretched out, and it's not like a nice tight elastic band like you would see around a bunch of broccoli that just goes back in place. This is one that you have around a newspaper. First time you pull it, it breaks apart. Okay? So talking about meniscus tears, because this is sometimes a source of confusion. Okay? What used to happen, it's been 25 years now, time goes by quick. When I was in medical school, we were just starting to use MRI scans. Okay? And back then, and even to this day, there's a lot of people that when they take someone, once you get past about the age of 50 and you start to develop some osteoarthritis, the MRI scan is going to show that you have a meniscal tear. Well, what happens is if you have a moderate amount of osteoarthritis and you have a meniscal tear, which you're going to have because the two go together, and you get part of that meniscus removed, okay, what you've done is you've added to the problem. Okay, you've taken out the cushion between the bones, understanding that the meniscus is not only a cushion, but it's also a spacer and a shock absorber. So, you're losing the thickness of the cartilage on the end of the bone, the shock absorber is wearing down, so let's take some more out. What happens then? Okay? Basically what happens, there was a study, took about 15,000 people, big study, Average age was about 54, equal males and females. They took people with a moderate amount of osteoarthritis that had some sort of degenerative meniscal tear. And again, the meniscus can tear a lot of different ways. It can tear like this here. You can have a little bit of a flap. You can have a flap this way. You can have a flap that way. And the meniscus, okay, the red zone here, is the part of the meniscus that has a blood supply. Okay, this part of the meniscus here, called the white zone, does not have a blood supply. So the analogy is your fingernail. Okay, the red zone, or the part of the meniscus that has the blood supply, is like the pink part of your fingernail. If you get a tear in the red zone, most often it's going to heal up on its own because there's a blood supply. If you get a tear here on the white part of your fingernail, you've all experienced that. It gets caught on everything, it gets in the way, and you say, well, gee, how can something little like that cause so many problems? The first thing you do is you go reach for the nail clippers and you clip it off. Okay? Well, if you do that inside a knee that has osteoarthritis, you're going to speed up the rate at which the osteoarthritis progresses, and then usually within 5 or 10 years, if you get an arthroscopic removal of a meniscus when you're 55 or 60, within 10 years you're going to have a joint replacement, which is a good thing if you're the same guy doing the meniscus and doing the joint replacement. You never go out of business. Okay, but all joking aside, if you take folks in that age group and you do a medial meniscectomy, people are going to fall in one of 3 categories. They're going to get better for about maybe 6 months, a third of them. About a third of them won't get any better at all, and a third of them will get worse. Okay, so the reason to go and operate on a meniscus at any age, okay, if you have a big flat tear where it's flipped over on itself like it's working like a doorstop, okay, where it's causing mechanical symptoms where your knee can, or let's just use a knee here, if the knee is blocked where it doesn't move, that meniscus that meniscal tear needs to come out, because if it doesn't, what it's going to do, it's going to rub back and forth on the cartilage on the end of the bone and wear it off. Okay? If a knee stays persistently swollen and it's due to a displaced meniscal tear, usually you got to take it out because it's irritating the joint, and when the joint stays irritated, it produces more bad substances. And the other thing that really happens, it doesn't take much for your quadricep muscle to shut down and atrophy and get weak, and that kind of adds insult to the injury. And the third reason is if there's just pain that you can't tolerate and you can't function. Okay, but in most folks in the age group, the people that I see here in the room, with the exception of the young lady there and the young ladies in the back, if you leave most of these meniscal tears alone, after about 4 or 5 weeks, people are going to do fine. Okay, and you've kept things in there, and I've been practicing for over 25 years, and in most times that's the case. But if you have one of these things and now it's 6, 7, 8 weeks and you can't function, you can't go to work, or you can't do anything, yeah, then you got to go in and do something about that. Okay, so we're going to talk some about tendons, because we treat tendons as much as we treat osteoarthritis. Again, the tendon is the rope that attaches the muscle to the bone. Okay, and the way a tendon is constructed, it's kind of like an electrical cable. I don't know where my green light's at. Okay, with thousands of fibers kind of woven together, kind of like in a helix. And when this process starts, due to repetitive injury or little micro trauma, you get tiny little tears in the individual fibers. Okay, and those tears heal up with scar tissue. Okay, and what happens when the tendon heals, it doesn't heal up in those nice straight bands. It starts making a lot of scar tissue. Now the tendon doesn't stretch back and forth, and when it heals up with scar tissue. That's what we call tendonosis. It's a wear and tear change. Okay, and very common, I'm sure everybody in this room has had one form of tendonosis or another. The muscles and tendons that move your wrist, hands, and fingers, they attach to the bone on the outside part of your elbow. We call that tennis elbow. Okay, the tendon below your kneecap, called the patellar tendon, that is also very common. The Achilles tendon, in folks that like to run, jog, or jump, get problems with the Achilles. The hamstring tendon that attaches up to the butt bone, also very commonly injured. Okay, The rotator cuff is one that gives people a lot of disability. This kind of shows an early stage here where you just have tendinosis, where you have the wear and tear changes of scar tissue that doesn't stretch, doesn't have the same elasticity. So what happens is you use the tendon in a normal fashion. Eventually what's going to happen is that weak tissue is going to get a partial tear where it starts to pull off the bone, and eventually you can get a full tear where it comes completely off the bone. Okay? So again, a normal wear and tear process that again can be started by one injury, but more often tendons of repetitive use over and over. Runners, tennis players, anything that people are doing the same thing at work every day will eventually wear their tendons down. With the Achilles, you can actually see the amount of scar tissue. You just see this big bump right here where it looks normal on the other side. One of the reasons that I got into PRP and eventually stem cells is, 6, 7, 8 years ago, we didn't have much we could offer patients, okay? Because a tendon is a tissue that doesn't have a very good blood supply to it. So if you operate on a tissue that doesn't have a good blood supply, how's it going to heal? So that's one reason that, for instance, rotator cuff tears, because you're operating on tissue that has scar tissue, has a 1 out of 3 chance of failing, okay? It's not because you had a bad surgeon, okay? It's just that tissue is very tough to heal. We had a fellow come in, I think it was back in 2007, 2008, when we just started doing this. And I was reading about it, and there's not a good operation for an Achilles tendon. It has tendinosis. Yeah, if the Achilles tendon tears in half like you're cutting a rope in half, that needs to be repaired, okay? Although we've had people that can't have operations that we've treated with platelets and they've healed up. But I treated one of these people. He was a runner, and he came back about 6 weeks later, and as sad as it sounds, I sometimes forget my right and left real easy. So I'm looking at this patient's ankles, and I said, I know this guy had a bump, but I couldn't remember if it was on the right or the left side. It went away. And he said he felt pretty good, and I said, maybe we're on to something. So, we've done a few thousand since then, and we've learned a lot what works and what doesn't work, okay? This is just a picture. This is an ultrasound picture. Yes, sir?
I'm sorry, I don't know when you want questions now, now or later.
Well, I'll probably be finished here in maybe about 15 or 20 minutes, if that long, and I'll just open the floor to questions, okay? We use a lot of imaging when we take pictures of tendons, and we've used a lot of ultrasound because we can use it right in the exam room. We get a picture right away. For the structures that are very close to the skin, it actually gives us better resolution than an MRI scan, looking deep inside a joint to see if you've lost cartilage from osteoarthritis. An MRI scan is still better. This is just an example of a lot of scar tissue. That's that bump that you just saw. And eventually what happens through that scar tissue, you get a tear in the scar tissue. And that's why when you go to therapy and stretch and take your medicine, you just don't get better. You don't get better. You rest it, it gets a little bit better, but it comes back and people say, well, I rested, it should go away. Well, if you have a tear in there and tissue that can't heal, generally it's not going to go away. So how do we treat this? Okay. And we use our own body's products, stem cells, and platelets, which have shown us very good results. Okay, let's talk about a little bit about stem cells. Okay, these are our body's repairmen. They repair bone, muscle, cartilage, and tendon. Okay, there's a few different types of stem cells. Mesenchymal stem cells. Okay, they will only become connective tissue. Bone, tendon, ligament, cartilage. If I take your mesenchymal stem cells and put them in your hip, you're not going to grow an eye in your hip, okay? We're not talking about embryonic stem cells, okay? If you take embryonic stem cells from a fetus, you can grow any type of cell that you want, okay? And, there's a lot of folks nowadays when their children are having, when they cleave the stem cells from the placenta, okay? Because those stem cells can be used. They're that baby's own stem cells, they're that person's own stem cells, and they can be used later in life to treat anything from osteoarthritis to tumors and cancers, okay? But we're not talking about those type of cells. We don't use those. These are the ones that just go in the connective tissue, okay? These stems are autologous, meaning that they come from the same patient, okay? So you don't have to worry about genetic disease being transmitted. You don't have to worry about tissue rejection. You don't have to worry about allergy. It's your tissue, okay? And where do these cells live? They live in the bone marrow. They live in adipose tissue, which is fat. They also live in the muscle, and they also live in the perivascular tissue. What that is it's the circulation, the blood vessels that go through that connective tissue in the joints. So part of what happens when we treat with platelets and stem cells, not only are we putting the stem cells in there and the platelets, but we're also releasing the stem cells that are already there, kind of waking them up and activating them. And we also have them in the peripheral blood, okay? So if you've read anything about stem cells, or you've gone online, you know, bone marrow and adipose-derived stem cells are the most common sources that we use. If you take stem cells from fat, okay, you are going to get a lot more stem cells than if you take them from the bone marrow. The stem cells that come from fat are not biologically active, meaning they're like, you know, if you look at fat tissue underneath the microscope, there's a lot of connective and fibrous tissue in there, and the stem cells are attached to that fibrous tissue almost like grapes on a vine, okay? As long as those grapes are on the vine, they're not biologically active. The stem cells that we get from the bone marrow, they are biologically active. So per unit, you may get more stem cells from fat, but they're not going to work unless you do a process called SVR, which is a stromal vascular fraction, where you do an enzymatic process where you pull the grapes off the vine. The FDA says we can't do that in this country because if we do, we've created a drug. The other thing that we're not allowed to do in this country is we cannot culture or grow your stem cells unless you're in a research center. The rest of the world has been doing that for years. They can take your stem cells, they can grow them, they can give you a new heart, they can give you a new liver. Believe me, they're doing this in Korea, they're doing it in South America, but the FDA says we cannot do it here. Because if we do it, we've created a drug. Now, why would the FDA say that? The FDA says that because they're being lobbied by the big pharmaceutical companies that understand that they can make billions on this, and at some point in time in the near future, they probably will. But that's the politics behind it. Okay, we still get good results with what we can do. Okay, but if you go somewhere else in a different part of the world and get stem cells for your hip osteoarthritis or your knee osteoarthritis, you're probably going to get even a better result than you get by doing it here in the States. Okay. So are there any risks with these stem cells? You know, like I said, they're your own cells, so there's no risk to the patient of any genetic problem, infection, anything like that. As of this year, there's been over 10,000, well, probably 11,000 studies since I put this together, studying this here. And again, we just talked about what the FDA says. And when you take stem cells from the bone marrow, there's less side effects. You know, I've asked patients who've had, if anybody in here had stem cell transplant or a liposuction. But basically what you do is you do a mini liposuction and you get the fat cells out. And people will tell you getting the bone marrow aspirate is much more comfortable than trying to get a liposuction. A lot of people want a liposuction. They'll say, "Doc, take a little bit off here, more here." I say, "I'm not a plastic surgeon. I'm the wrong guy." You know. But so what is PRP? PRP is a preparation of platelets that we concentrate anywhere from about 3 to 20 times above normal, and we get rid of the red cells and the white cells. Well, what is a platelet? Okay. Platelets are these little particles that float around inside your bloodstream. Okay, they break off from bigger cells, and they basically, there's a very fine balance going back to that term homeostasis of our clotting system between keeping us alive, your blood being too thin, where if you cut yourself you bleed to death, or if your blood's too thick, or this clotting system gets thrown off, you can get a blood clot or a pulmonary embolus and you can die from it. Okay, but basically what the platelets do is is when they're exposed to injured tissue, they release proteins into your bloodstream that are called growth factors. And then they recruit your body's stem cells to the site of injury. Best way of thinking how a platelet works is you skin and cut your knee. Okay? Eventually you see a scab. Scab comes off, you have pink skin, and after a while you don't know what you scraped your knee or if you get a cut on your skin. That's what the platelets do. They're exposed to the injured tissue. They release growth factors in your circulation, and they have the stem cells come to the site of injury, and then they help the wound heal. Okay? And basically what they do is it kind of kickstarts or accelerates the process of healing. There's 3 steps to healing: the inflammatory process and the proliferative process, where there's repair, and there's a mature, where most of the time it can lead to scar formation like we talked about in tendons, and the PRP kind of circumvents going to a scar and gives you healthy tissue. Okay? So when do you use stem cells and when do you use PRP? Okay? PRP we most often use to treat tendon injuries. Tennis elbow, hamstring, Achilles tendons. Platelets, that's a high oxygen area, and platelets work well in that. We use stem cells some with tendons. In other words, if you have you can use it if you have a partial thickness tear where half the tendon's pulled off the bone, or you have a hole in the tendon, you can use the stem cells with the platelets. Okay? We always use platelets with stem cells to treat osteoarthritis. Stem cells don't work without platelets. Okay? Platelets are kind of like a construction manager. They will tell the stem cells to start dividing. They will tell the stem cells that you need to be bone, tendon, ligament. They'll tell the stem cells to produce chemicals that stop the toxins, all that sort of thing. PRP can be used some for arthritis. And the one thing I didn't talk about was the severity of arthritis. So if you get an MRI scan and someone says, well, you got bad arthritis, or you got grade 3 or grade 4, what does that mean? What that means, if this wall board here is the cartilage on the end of the bone, and the stud underneath it is the bone, grade 1 loss is just a little ding in the cartilage. Okay? Grade 2 goes about 1/3 of the way through. Grade 3 about 2/3 of the way through. Grade 4, you're down to the bone. Okay? So if you have osteoarthritis where you have maybe grade 1 and 2 cartilage loss, PRP by itself works very well for that. Once the cartilage loss is down to grade 3 and 4, PRP is not enough. You have to use the stem cells with the platelets. And there's always exceptions to that, but that's kind of a general rule of thumb of what we know right now in December of 2015. What I'm telling you in December of 2015, some of this is going to change, by December of 2016. For instance, a couple of years ago, when people came in with 2 bad knees or 2 bad hips, we draw the stem cells and put them in both knees or both hips. And what we found, that the results weren't as good. And the results weren't as good because in most folks that have that much arthritis in both joints that they need stem cell treatments, we weren't getting enough stem cells. So the results weren't as good. So the way we kind of got around that is I have a good friend I used to play racquetball with was a hematologist. I asked him, how long, if we do 2 joints, do we have to wait to do the second joint if we're going to take stem cells? In other words, your stem cells are kind of like your reservoir. The other thing that happens in the bone marrow is the bone marrow makes all your other blood cells. It's like the tank, the reserve tank for everything that goes out in your circulation. So if we take anything out of that tank and we want to get a good number of stem cells for another treatment, we have to wait about 6 to 8 weeks. So if we're looking at 2 knees or 2 hips, sometimes 2 shoulders, depending on the age of the patient and how much arthritis, generally we don't do those together. Now, if it's, let's say it's a knee and a wrist, usually we can do enough to get 2 joints like that, or if you have 2 small joints, it can work, but the information that's coming out is changing quite readily, okay? And like I said, some tendons can use both. PRP can treat early osteoarthritis, but advanced osteoarthritis, you need stem cells and platelets, okay? So when we use PRP, most people will need 2 to 3 treatments spaced about 4 to 6 weeks apart, and it takes at least 6 to 8 weeks from the time you get the first treatment when you're treating tendinopathy or when you're treating osteoarthritis to feel any different. Okay? This is not a shot or treatment to take away your pain as much as it is a treatment to try to heal the tissue. So it takes time to shut down the production of the substances that are breaking down the tissue and for their effects to go away. And then it takes time for the beneficial products to start doing their things. So that usually takes about 6 to 8 weeks. Now, you've probably heard about athletes that sometimes get a PRP injection and they're back on the field in 2 or 3 weeks. That will happen with a fresh injury, usually to a muscle. Okay? So let's say you got a basketball player that's got a little partial tear in their hamstring muscle, not their tendon. You give them PRP, they're probably going to get back on the field 50% quicker. If you have a soccer player or a hockey player who has a groin injury and you put PRP in it, they get back very quickly. Part of the reason for that is the muscle tissue is very vascular, has a lot of blood supply to it, so everything happens much quicker than in a tendon that doesn't have much blood supply, or in the end of a joint or an environment where there is no blood, like inside a joint. Okay. Overall, for what we've treated here at Beacon over the years for tendinopathies, our success rate's well over 80%, but it's lower in folks that are cigarette smokers. It's lower in folks that have diabetes, because both of those things, what they have in common, okay, is what they do is they shut down the little blood vessels. Okay. If you know anybody that has diabetes, or if you have diabetes, you know your doctor's going to put you on medicine to keep blood flow going to the kidney. You go see the eye doctor so you can make sure you can see what diabetes is damaging it. But the same thing happens in tendons. Okay, if there's not a good blood supply, tissue can't heal, and the anti-inflammatories such as aspirin, Aleve, ibuprofen, those medicines, while you're getting this treatment, you have to stop, because the anti-inflammatory medicines, they keep the platelets from doing their job. It's the opposite of the, and again, people with heart disease go on aspirin for a reason. If you've had a heart attack and you take a baby aspirin a day, the risk of getting a second heart attack goes down by 60%, because that aspirin is keeping the platelets from sticking together and releasing their growth factors, because the reason people get heart attacks is the lining inside the blood vessel gets damaged. Okay? If you remember that one slide, platelets become activated when they're exposed to damaged tissue. So now you have a damaged tissue on the inside of your blood vessel, platelets stick to it, now you got a blood clot, blood can't go through, you get a heart attack. Okay? Now, natural anti-inflammatories like fish oil, turmeric, those are fine to take. Okay? The way we treat osteoarthritis here, it's a 3-part treatment. Okay? The first treatment that we do is called a Prolotherapy treatment. Prolotherapy has been around forever. We use a dextrose solution. Dextrose is a naturally occurring carbohydrate produced and utilized by our body for energy. Okay? We ramp up the concentration, and basically what it does when you inject it in connective tissue and inside a joint, it's trying to wake up your body and say, hey, we need to try to fix this. We got to get rid of this bad stuff in here that's breaking down the cartilage. Okay? That treatment maybe takes about 10 to 20 minutes. You can walk in and out the door. And then we have you come back in about 3 to 7 days. Okay? And at that treatment, if we're treating osteoarthritis with stem cells and platelets, you're going to be at the office for a few hours. Okay? Generally what happens when you come in the door, girls will say good morning to you, smile, bring you back to the room, have you take your clothes off, get in one of those fancy gowns, that sort of stuff. But then we get your blood drawn, and then that's taken to the lab, and then we get the stem cells from the bone marrow in your iliac crest, which is the bone right above your butt cheek. Okay? We use ultrasound to identify that part of the bone, and we numb it up so that when we use the needle to get the bone marrow aspirate out, you don't feel any sharp. A bone marrow aspirate is not a new procedure. I learned to do that about 30 years ago when I was in medical school. Hematologists, oncologists, they do it every day. That's how they diagnose anemias and different types of blood cancer. So we're just using it to get the stem cells out, okay? And both the stem cells and the platelets get injected back in the affected joint the same day. And then what we do is we see you back about a week or so later, and you get another platelet injection. That platelet injection is kind of like getting a booster shot, or it's kind of like if you just seeded your lawn and it needs fertilizer. That's what that PRP injection does. Okay, so that's basically the treatment right there for treating osteoarthritis. And again, it takes about 6 to 8 weeks before you notice any difference in how your joint feels. Okay, it's not going to happen overnight. Usually takes about 3 to 4 months before you say, boy, doc actually did something to me. Okay, it's just a process. It takes a while. And I was telling people up until a couple months ago, it takes from anywhere from 4 months to 12 months to get as good as you're going to get. But information that's come out recently in the last 4 to 6 weeks where people have been treated, they looked at people with knee osteoarthritis treated with stem cells that have had a response, let's say at 12 months, and they're surveyed 24 months or 36 months later, they're still getting an improvement. Okay? So oftentimes, what happens is the response takes a while, but people do get better. And based on the amount of osteoarthritis that you have in your hip or your knee and your shoulder when you come in, is also going to determine not only your chance of responding, but what kind of activity you're going to be able to get back to. Okay, in other words, if you're the gal or the guy that came in with that bone-on-bone osteoarthritis, and you say, Doc, I want to run a marathon in about a year, okay, our conversation is going to be over in about 5 minutes because that's not going to happen, okay? Because again, what has to happen for this to work is the repair process has to outpace the breakdown process. So if you're doing normal walking, or you're doing swimming, or you're riding a bike, and you're not pounding on a joint that's bone on bone, the repair process is going to outpace the breakdown process from pounding on the joint. If you have bone on bone, and let's use a knee for example, or a hip, and you have nearly full motion, and you're not having to take a lot of pain medicine, what this treatment can often do is obviate or avoid a need for a joint replacement, plus get a lot of function back. So in other words, if you come on with bone-on-bone arthritis, and you say, I want to walk in the neighborhood with my friends every morning, we can probably help you. If you say, I want to be able to walk 9 holes a few times a week, we can probably help you. Okay? If you don't want to get a joint replacement, and we look at your physical exam and what we find on x-ray, sometimes MRI scan, we can kind of prognosticate the chances of the treatment helping you, okay? The other thing that we do is usually about a week or so after you've had your last treatment, we will have you start working with the physical therapist, okay? Because what happens, and anybody in this room that has osteoarthritis, and I'm assuming most people are here because they do, myself included, once a joint starts to hurt, you start to use it less. Because you start to use that joint less, it gets weaker. Now because it's weaker and you try to use it, it hurts more, okay? And it's important to keep a joint strong because the stronger you keep a joint, the more limber you keep the joint, the slower the osteoarthritis progresses over a period of time, okay? So if we don't break that cycle of pain, disuse, weakness, you're kind of like a snowball going down the hill. So while this treatment is helping and starting the healing process, okay, it will help the arthritis in a joint, but it's not going to make your thigh muscle stronger. It's not going to make your hamstring muscle stronger. That you got to do on your own, okay, with the physical therapist. With the stem cell treatments, there's certain type of medicines I'm not going to get into detail that need to be stopped, but we kind of go through that process. If you come in the office, and we talk with your family doctor if necessary as well. Okay. I mentioned that we've been doing regenerative type medicine here since 2007. A couple years ago, we switched over to Regenix. Regenix is out of Colorado, okay? And one of the reasons we switched there is we make our own PRP and stem cell product here. We don't use a kit from a commercial drug company, okay? I did that for years and it worked great, but we find out there's different applications of what you need to use. For instance, if you put PRP in your elbow, the platelet concentration can probably get by with about 6 times normal. If you're going to use PRP for osteoarthritis, you want your platelet concentration to be about 12 times normal. You can't do that with a commercial kit, okay? The way we prepare the stem cells in the lab, we get much higher yields than with any other method, okay? So, and again, I didn't do this. It's the scientists that came up with this, and I've been fortunate enough to become part of it, over a period of time, okay? And again, they have full-time cell biologists and biochemists. That's all they do all the time is, doing research, what's working, what's not, do we do this, do we not do that? So again, keeping up with this, things that we might have done, 5 or 6 months ago, we're not doing now. And my staff sometimes looks at me cross-eyed, they say, Doc, when are you going to get it together? I said, well, things are changing, so we got to change along with it. So kind of keeps us from getting bored, okay? And then finally, this is probably the biggest benefit, is that Regenix has a patient registry and database where physicians across the country that are using these methods, everybody's data can get pulled together, okay? To this date, there's not much of that going on with regenerative medicine, okay? And the database with the Regenix patients is only about 8,000 people. And you say, well, gee, only 8,000. Well, if you look at things like atrial fibrillation, heart disease, diabetes, different types of cancers, those databases have hundreds of thousands of patients. It's been collected for lots of years all across the world, okay? But it's a start, and if you look at 8,000 patients versus, let's say, 800,000 patients, it's like a batting average in baseball. If a guy goes to bat 10 times and gets 4 hits, he's a 400 hitter. It says so, it's stats, okay? But is he a 400 hitter with 500 at bats over a couple years? We don't know that yet. We don't have those numbers, but at least we have a start, okay? So what it allows us to do, okay, is we can help folks determine if they're a good candidate for the treatment or not. That can be based on your age, okay, because as time goes on, we have less stem cells, we use them up, our body can't make them as quickly, and the example I use there, because we see patients of all ages, a 15-year-old that twists their ankle. 5 days later, running up and down the basketball court, okay? College athlete maybe takes 7 to 10 days. Now we're a recreational athlete with 30 years old to go play basketball, man, it takes 3 to 4 weeks for your ankle to get better. You get to be my age, it's going to hurt for a few months. Add another 10 or 15 years, that's just not getting better. You can't get back out, so as time goes on, the body will sometimes lose an ability to repair itself, but I can tell you, I don't know how many patients I've seen, over 25 years, but I've seen 85-year-olds come in much better shape than some 50-year-olds, okay? And I've seen some 50-year-olds in much better shape than 25-year-olds, so it's all how people take care of themselves. It's their body's genetic, what breaks down, what doesn't, okay? How much disease do you have? How much arthritis do you have, okay? We know that folks that have arthritis in every joint, okay, probably won't respond as well as the person that just has arthritis in 1 or 2 joints, okay? And then we know that with most joints, depending on how much, the more loss of motion you have, okay, then the success rate goes down some. Okay, we've seen people that come in, bone-on-bone osteoarthritis, can fully straighten their knee out. They usually get a good positive response. Okay, and one of the doctors, it's a Regenix doctor, he was the head of orthopedics at Rush Medical School for years. Okay, he developed Parkinson's disease, so he couldn't operate anymore. So he started getting into regenerative medicine, and because he's just this big university machine, he can kind of pump out this research because they get the grants and they get the patients and all that sort of stuff. And he was the one that figured it out. And I've seen his dad a few times, talk to him. You know, bone-on-bone osteoarthritis, if that knee straightens out, people are going to have a positive response. People that still have some joint space, but their knee is stuck like this here, or their arm goes up like this, but they can't point their toe very far, won't have a good response. Okay, and again, having access and knowing that sort of thing is tremendously valued for the patient. It also helps us as a staff in being able to treat. And we also look at the imaging findings. Okay, if someone comes in and I showed you those x-rays, there's no need to get an MRI scan. We know what you got, and we got a pretty good idea of whether it can help you or not. Now, some folks will come in with x-rays and look pretty good, and now you got the MRI scan that has a lot of osteoarthritis, but the meniscus is intact. So again, sometimes you need to do imaging beyond x-rays, oftentimes you don't. Okay, so that's the main benefit right there. That I will usually tell people, you know, you got a 3 out of 4 chance, 2 out of 3, 50-50 or less. Okay, and again, that's what we know right now. In December of 2015, that data may change in, you know, 12 months to you may find something different. It's okay, well, this is also a good indicator, this one maybe not so much. Okay, so that's about all I'm going to talk, and I hope I didn't bore you too much, but I'm certainly going to open up the floor, answer questions, stay as long as you like.
Yeah, obviously one thing we were wondering is we were told that this is not covered by insurance.
It is not covered by insurance.
So what ballpark, and that's change for each person depending on their severity of disease. Are we talking 1 to 5,000, 5 to 50,000? What kind of ballpark are we talking?
Well, if you're just getting a PRP injection, okay, a PRP injection, people need 2 to 3 of those. Those run about $700 a treatment. Okay, there's certain times when we're releasing scar tissue from the bone. Using a needle, that's procedure is called a percutaneous tenotomy. If I'm doing that procedure, we can bill your insurance for that procedure, and they cover the cost of the platelets if you get them. But if I'm not doing a tenotomy, in other words, I'm just putting PRP in a joint, that's not covered. A PRP treatment runs about $700. Okay, the combined treatment of getting the prolotherapy, the 2 platelet treatments, and the bone marrow treatment runs close to about $6,000. Okay, that's the cost. Insurance does not cover that. Okay, and there's a lot of different ways of looking at that. Okay, it's a huge number. Okay, I'm not, you know, and my hope is that within a few years it's covered by insurance. Then it becomes a completely no-brainer to do it because there's really not a downside. Okay, in other words, like to repeat myself, we're not giving you anything that doesn't belong to you. The tissue is yours. Don't worry about allergy. We do everything under sterile conditions, so infection is a minimal risk. It's, you know, anytime you break the skin, you can get an infection, but platelets are anti-infective. You know, 99 times out of 100, when you skin and fall your knee, you don't need to go on antibiotics. Everything we do is under guidance. Okay. So the worst thing that can happen with this treatment, other than hitting you in the pocketbook, okay, it may not give you the result that you want, okay? But we've had people that come in our office, okay, you got people every day that want surgery that may not need it. And you say, okay, you don't need it, you can go to therapy, you can do this, you can do that, okay? We have folks that come in, they say, no way is anybody putting a foreign implant in my body. You have people like that. Also, you may have folks that are high risk for surgery. They may have bad heart disease, or they may have had a previous joint replacement and it was a disaster. Let's say they had a hip and they had a blood clot and they got an infection, they had to stay in the hospital for a while. Now they have osteoarthritis in the other hip or one of their 2 knees. Okay, so it's just it's one of those things where it's certainly a high number. Okay, and again, it's how people feel about their body. People have no problem spending $5,000, $10,000, $15,000 to go to a plastic surgeon, or spending $5,000 to get your LASIK treatment. So you know, it's how you feel.
Plantar fasciitis was listed on that poster, but you have not mentioned it. I have that, and you know, there's a couple of out of the country trips that I need to go on, that I'd like to go on, and it hurts, every step hurts. How effective is this for plantar fasciitis?
Well, plantar fasciitis, what do you gals think? PRP may be the second or third most common thing we do after the elbow. I mean, we treat plantar fasciitis all the time. I would say that I can't remember the last time we treated a patient for plantar fasciitis that they went on to get surgery. Okay, like I say, it's one of those things. The biggest challenge in treating plantar fasciitis, if you have a job where you have to stand or walk on concrete all day, if you don't take that factor out of the equation, your plantar fasciitis is not going to go away no matter how we treat you. Okay, but it's again, if you're not diabetic and you're not a cigarette smoker, you know, we have electronic medical records. We're mandated to do that by Medicare, and we have fellows, and we are able to track our data. Okay, so you know, most of our patients that have plantar fasciitis generally need about between 2 and 3 treatments over a period of 6 to 8 weeks. Some folks we will put in a boot, maybe for about 6 to 8 weeks, because sometimes you don't know that there's a tear in the fascia until actually when you go in there and you do the procedure and you inject some fluid in there and you kind of see the tendon, like on that ultrasound picture I show you, where the tendon just kind of pulls apart. But it takes a while for it to get better, but the success rates are pretty good. We don't use stem cells for them. You know, you don't need to. The platelets generally. The other thing where with plantar fasciitis is there's a few nerves that go down to the plantar fascia. And the other thing that happens with tendinopathy and its pain, we didn't talk about that too much. You know, people always say, well, tendinopathy is due to inflammation. Well, actually, where most of the pain we believe comes from is the irritated nerve endings that get entrapped in that scar tissue. Okay? In other words, if I grab one of these wires over here, there's juice going through it, but I'm not getting shocked. Okay, what happens, if you remember that slide I showed you on tendons, those tiny little nerve endings get entrapped in that scar tissue. Now it's like a short circuit that it's constantly sending a pain message to your brain, even though there's not a painful stimulus. So in certain patients, and we examine them for this, if the nerves going to the plantar fascia are irritated, we treat that with prolotherapy. Okay, because the prolotherapy will help cool down an inflamed nerve.
Is that PRP? Is that what prolotherapy?
Well, we would do it. Sometimes we do a combination of both, depending on what the physical exam shows.
What was prolotherapy again?
Prolotherapy is where we take a concentrated dextrose solution, and you can use it a different way. When we use it in joints and for osteoarthritis, the concentration is between 12.5% and 25%. There's another type of prolotherapy we use. It's called Perineural Prolotherapy, where the concentration of dextrose is only 5%, and we adjust the pH or the acidity to be the same as a nerve cell. What happens when a nerve cell gets inflamed, if you look at an individual nerve cell like this room here, okay, it has receptors on it, or channels, that allow potassium and sodium to get in and out of the cell. When a nerve gets inflamed, that door won't open, that door won't open, and now the nerve starts producing substances that could produce pain. The right solution of dextrose and the right pH will start opening those doors again and help the pain go away. And most of the time you do that, we don't even have to put numbing medicine. We do it around the foot because it's sensitive. And actually, a guy that figured all this out, he's from New Zealand, and when he did his research, what he found out, it's the same solution that a rabbi uses to do a bris, and there's no anesthetic. So
just comparatively, I know I've been to podiatrists, and you know, they give me the boot, and they stay off your foot. You know, it's been 2-3 months already, not any better. I've got a trip coming in April, a trip coming in July. If I don't do this versus doing it, what would be the shortening of time ballpark?
I mean, for you to go on a trip and let's say you're going to Europe and you want to be able to walk 4 or 5 hours a day for 5 or 6 days and see the sights, you're probably going to need a good 3 to 4 months before you get to that point. from the time you get treated.
Yeah.
Yes, sir.
At the beginning of your answer, you mentioned an additional treatment that could be covered by insurance.
For tendinopathies, yeah.
So is that like a scar tissue removal?
It's called a tenotomy. Okay.
What is that exactly?
Well, what that is tendons most often get injured where they attach to the bone. Okay. And what a percutaneous needle tenotomy is, percutaneous means we're going through the skin. We're not making an incision. We're not opening anything up. Okay. Needle, because that's the instrument that we're using. We're not using a scalpel, drill, blade, hammer, chisel, anything like that. And a tenotomy is loosening up scar tissue and untethering it. If you have a condition that the procedure we would do would be a percutaneous needle tenotomy, okay, we do that procedure and use the platelets to kind of augment it. Okay, insurance doesn't cover the cost of the PRP, but if I'm doing a tenotomy and that's the main procedure that I'm doing, we can bill the insurance company for it. If I'm not doing a tenotomy and you're getting PRP, let's say you're getting it in a muscle, or you're getting in a tendon that's partially torn, or you're getting it in a joint, there is no percutaneous needle tenotomy being done, so PRP is what you do. Yes, sir.
You never mentioned the spine. Have you done anything with the spine?
I personally do not treat the spine, and here's why, okay? We have 5 spine doctors in our practice, okay? So when people call in, they mostly go to the spine doctors. The spine is very complicated, and for me, I'll be honest with you, for me to try to learn how to do the spine and do what I'm doing now, I would have to give up a few things I enjoy doing. One of them is sleep, another one is cooking, another one is exercising. It's just not, but in answer to your question, a couple of our doctors here have started doing the Prolotherapy treatments. We have a very good group of physicians up in Toledo that will treat the spine, and we also have a good group of physicians in Pittsburgh that will treat the spine, both the lumbosacral spine. I don't do it because honestly, if I'm going to do this, I want to be good at it. And you get good at it by doing the same thing over and over. And I don't see enough back patients. And like I say, for me to learn how to do the spine, I would probably have to shut down everything else for 4 or 5 months to learn how to do it.
Yes. Question. It seems like every time that a joint in my body gets examined because of an injury or something, I'm told you did or didn't tear something, but oh, by the way, you have arthritis there. Okay. So now I keep finding I have arthritis here, I have arthritis in my spine, I know, I've had a tendon repair here, I have a rotator cuff 5 months ago down here, and each time they tell me, oh, by the way, you have arthritis there. I don't feel the pain of arthritis anywhere except here.
Right, right.
Do you do this therapy before there's pain from arthritis or not?
Well, I'm going to answer your questions because it's a couple of different things, okay? I spoke both of arthritis and tendinopathy because they're 2 different problems, okay? Tendinopathy, your rotator cuff, that involves the tendons. Arthritis is a loss of cartilage off the end of the joint. Now your joint, let's say your shoulder, can hurt for a couple of different reasons. You can have arthritis in the ball and socket part of the joint. You can have a rotator cuff tear in a tendon. You can have a tear in the cartilage. Or you can have a combination of all of them if you're really lucky, okay? But in answer to your question, a lot of people will come in and their arthritis is asymptomatic. In other words, when you come in, I'm going to be 57 years old, okay? You take an x-ray of my right knee, it's going to have arthritis there, okay? Right now the knee feels okay because I've been treating it and that sort of thing, but the arthritis has been there. It starts, it takes 10, 15, 20, 30, 40 years to develop it, but at some point in time, something happens, something breaks, so there's a straw that breaks the camel's back. You step in a hole. Or now the cartilage loss is enough that you start to feel it, and it starts to cause symptoms, then you come to the doctor. In terms of, you're asking about treating it, okay? Like I said, if this treatment will be covered by insurance, okay, the 35 and 40-year-olds that are walking around out there with grade 1 and 2 cartilage loss, you give them this treatment, you've cured their knee. But they're not coming in to see the doctor because they're too busy living life, and the pain doesn't slow them down. It's, I'm tough, I'm going to work through this. But eventually, you know, just looking for the audience here in the room, eventually it gets to the point where it interferes, you're changing the quality of life, now you're going to go see the doctor. Yes, sir.
Question, I have Achilles tendonitis. It's not as bad as in the picture maybe happens, visually obvious. I tried physical therapy, the move for 6 weeks, ultrasound and the dry needling, to no avail. My question is, this is besides my age of 66, which doesn't help. This is about 2 years old. Does the length of time have is that a factor in the chances for recovery?
That's a great question, because for most problems that folks come in with, say their kneecap has popped out of place and it's been achy sore for 3 or 4 months, or they've had a little bit of rotator cuff tendonitis for 6 weeks, usually a rough rule of thumb, it usually takes your symptoms the same amount of time to go away with treatment as you've had them prior to you've come in. Okay. Now you guys talked about both Achilles, tendinosis and plantar fasciitis. You know, when people come in that have had plantar fasciitis for 4, 5, 6 weeks, I have my staff go in there, give them a home exercise program. If you do the home exercise program, most of the time it's going to go away. But quite honestly, most times people come in the office, I would say the average time people have had plantar fasciitis or Achilles tendon has been well over a year, or when our partners send them to me. You know, it's one of those things like, and again, I treated my Achilles with platelets, and I complained and hemmed and hawed forever and ever, and finally I found the time to go ahead and get it treated. And it probably took about 4 or 5 months to finally go away. But yeah, you know, if you have it for 2 years, it's not going to go away overnight. But we did a study when we first started doing this. We only had about 25 patients in that study because we wanted to see what was going on. We took 25 runners that were averaging about 20 miles a week. The average age was 49. I think there were like 21 males and 4 females. It took them, the average time to get back to running was, I think, about 4.5 to 5 months to the point. But like most people, because this is a chronic, ongoing problem.
So to make sure I understand then, so it doesn't really affect the ultimate chances of success. It affects how long it takes to reach that point.
Not exactly, both. It can, I mean, if you have, you know, I think you saw that picture, that swollen Achilles tendon, okay? And if you have an Achilles tendon, it's, I mean, we've seen some that are like that thick. I might say, I don't know, you know. But most people do respond, but the longer you've had something going on, the longer it's going to take to get better. And you will get some improvement. Most people will always get a little bit of improvement. Sometimes if you've gone too far, you may not respond. And that's kind of what we found out with significant loss of motion in the joint with osteoarthritis, okay? Again, you know, the top 5 that we do PRP for are probably the elbow, plantar fasciitis, Achilles tendon, patellar tendon. Those walk in our office every day, hamstrings, that's, you know, and again, we don't see them so much in runners coming in when they're 30. You know, we see it in runners when they're in their 50s and 60s and, you know, beyond. Yes, sir.
You mentioned that if you went internationally, because they've done it for so long, you'd likely to get much improved results.
Right.
When do you think we might catch up, or will we ever catch up because of the big pharma problem?
That's
It's good. Anybody's guess is as good, right?
yeah, I mean, I keep, you know, I guess there's been a lot coming out that, you know, I guess Obamacare is in trouble because there's not enough, so things may change yet. You know, I'm an optimist.
Do you do any work internationally? I mean, have you gone and...
I have. When I went to Colorado for the last meeting, the subject came up about going down to the Cayman Islands, and the way you got to do that is you got to get 5 or 6 patients here from Cincinnati that want to go down to the Cayman Islands and have $40,000. I mean, it's an astronomical amount.
Yeah.
Kobe Bryant and those guys.
Well, they go to Europe.
Yeah, they go to Europe.
Yeah. Yeah.
Where would you stay away from?
Hard?
Stay away from
Mexico.
You mean to get the treatment?
Iraq.
Don't go to Iraq.
Probably wouldn't go to Syria. No, I mean, but I mean, there is a track record. I mean, you know, for instance, you know, the cutting edge of people that really have this stuff down, and I've read the literature and I've met these people at meetings in South Korea. I mean, they are on the top. But you know, if you go 100 miles north, you're in North Korea. You know, they're not doing it there. Yes, sir.
You didn't go into a whole lot of technical detail about the difference between the kit and the Regenerics.
Okay.
I don't really understand.
Okay. What happens is, let's use Harvest for example. Okay. What happens with Harvest is you get a little, you draw the blood, you put the blood in a little cylinder, and you kind of spin it.
hip harvesting.
I'm talking about PRP.
Okay.
I'm assuming that's what you're asking. Okay. We take the PRP and we take it in the lab. Okay, and we process
Draw blood,
it.
spin it down. What's the origin of the PRP?
It's no, the origin from the PRP is still your bloodstream. It's that we're processing it in the lab, tailoring it for each patient, concentrating it at a different rate that you can do when you just put it in a kit and spin it.
Okay. Gotcha.
Yeah, and the biggest advantage, you know, that is, and again, we're learning all the time. You know, you know, when we first started doing this, okay, people, I mean, treatment, it used to be very painful treatment. And then we figured out, well, I'll do nerve blocks, and that helps some. But what we found out is most of the white blood cells, that if you don't take them out of the PRP, cause a very, very strong inflammatory reaction, where people really hurt for a couple of weeks before they even cool down.
Yeah, I've had PRP. It's painful.
Right, and what we're finding now is not all white blood cells are bad. The majority of white blood cells that are in your circulation are called leukocytes. And the leukocytes produce a lot of those pro-inflammatory things that break stuff down if you got too many of them. There's other type of white blood cells called lymphocytes. Lymphocytes, and there's only a few places in the country that have the ability in their lab, and it's not being used anywhere other in research, where you can keep the lymphocytes in with the platelets, and now you're even getting a better result with that. So again, in a few years, that's something that we might be able to do in a normal clinical lab, where we can separate out the lymphocytes from the leukocytes.
You talk about on your website, clear PRP versus
Bloody
non-clear
PRP.
bloody
Yeah, we take out all the red blood cells. Because go ahead.
So that's the Regenerics. That's the Regenerics.
Right. It's just platelets.
different. Okay.
Yeah.
So is, you know, people talk about, when I've heard people having, say, a bone marrow transplant because of cancer or whatever, I've never had that. They talk about that's a very painful procedure. Is this a painful procedure, the removal of something from bone?
Well, the actual harvesting the platelets, it's like any other blood draw. Okay. The bone marrow aspirate, like I say, we make sure the bone is numb. You know, people will feel a little bit of a deep, achy pressure. Okay. But what I notice is that, excuse me, when I do a bone marrow aspirate, patients don't flinch. When I use a skinny little needle to inject in the skin, they flinch more with that than they do with the bone marrow.
I don't know what they mean when they say, "Oh, bone marrow transplant is very painful."
That's a whole different, yeah.
Okay.
But in terms of, you know, for instance, you know, well, what about when you get plantar fasciitis? Most folks, after they get a PRP treatment, they're going to have some discomfort, achy soreness for a few days, where they can either take Tylenol or Tramadol. And probably about 1 out of 12, 1 out of 15 patients, when they get any PRP injection, at least the way we're doing it, anywhere from maybe 2 or 3 days, maybe a week, they're going to hurt to the point where they need to take pain medicine. But it's down probably to about 1 out of 15 patients. So you'll be sore for a while. Yes, ma'am.
Are you having a lot of people that have had rotator cuff surgery coming to you because they don't want to go through that again?
Well, actually, most of the patients that have had rotator cuff surgery that have come to me for PRP have come to me from my other partners. No, seriously. You know, that they do a rotator cuff, it didn't get better, okay, you can try this, or we try another operation. So no, most of the, you know, over a period of time, and they get changes, you know, who are treating, but, you know, for a long period of time, most of the rotator cuff tears that we treated were ones that didn't heal with surgery. And we had pretty good results.
So I had rotator cuff with your facility.
Mhm.
So if I go to my doctor, will he recommend you? Is that a given, or is that just?
It's not necessarily a given. You know, I'll be perfectly honest, everybody has their bias. Okay, surgeons are trained to operate, that's what they like to do.
Right.
Okay. You know, I do regenerative medicine, and when most folks come in and we talk about stem cells, and if you're a candidate, we're going to talk about 30, 45 minutes. Okay? If I see that you're not, as I say, this isn't going to help you, okay, I'll be honest with you from the get-go. Now, in terms of a rotator cuff tear, if you have a tear where a big part of it is pulled off the bone still, you go back and see the surgeon. Or some of what we've done here with, sometimes what will happen is, and we've done a number of patients like this, they may have both problems. They may have a surgical problem and a problem that can be treated with regenerative medicine. For instance, we talked early on about having a loose body in your knee with bad osteoarthritis. Well, the stem cells and platelets aren't going to take care of the loose body, so I may have them send them to one of my associates. They'll take out the loose body, and then I'll come back to me and I'll treat the arthritis with stem cells. So depending on how your rotator cuff is torn, if it's a small partial tear that hasn't pulled off the bone or it hasn't healed, you'd probably, you know, be helped by PRP. If it's where, you know, half the tendon is still pulled off the bone, that needs to be reattached.
Well, you've got great surgeons, I remember.
Yes, absolutely. I mean, they've operated on me and my family members.
Right.
Yeah, absolutely.
Yeah.
And the guy that does hip and knee replacements here does a great job. Absolutely.
Thank you.
You're welcome. Yes, sir.
So for a tendon, you gotta get the needle right in the tendon, right?
Yeah, we do it under guidance, yeah.
And then for a joint, you just like, for osteoarthritis, you're just kind of like bathing the surface of the...
For most of the osteoarthritis that we treat here, where it's grade 3 and grade 4, what we're doing is we're putting the stem cells and platelets inside the joint, and we're also putting them, depending on what side of the knee the connective tissue is worn out, we will also put the stem cells and platelets in the connective tissue that is stretched out like a rubber band, and try to get that to heal up so the knee gets some stability back.
Plantar fasciitis, is fascia tendon material?
The plantar fascia is a strong tendon. I don't have a picture here. It attaches to your heel bone and spreads out to your toes. And again, it's made of thousands of fibers kind of woven together. And so it's basically a tendon, same type of structure. Well, I appreciate you all coming out. I hope you learned something.
Thank you.
Thanks. Thanks for coming out.
Where do you say dinner was?